Assalamu alaikum wa rahmatullahi wa barakatuh. Let's begin with the name of Allah. I think this topic will be the last topic of this respiratory system. So we have learned about different clinical manifestations of respiratory system till now. Now just a glimpse of clinical examination findings which we will get when we are examining a patient of respiratory disease. So this is important. So I thought we should have a discussion on this. So let's begin with the name of Allah. Clinical examination findings in the respiratory disease. Immediate pointers to respiratory disorder, whatever its origin. So what are the immediate pointers which will say you that it is a respiratory disorder, whatever may be the origin of the disorder. So these are: number one is repeated cough. Repeated cough. Wheeze is a sign of respiratory disorder. Stridor, upper respiratory or large airway obstruction, is a sign of respiratory disorder. Painful breathing, pleuritic or any painful breathing, so that is also a sign of respiratory disorder. Labored or ineffective breathing, cyanosis. So 1, 2, 3, 4, 5, 6. So these 6 are the signs of these are signs which point towards respiratory disorder. Okay. Repeated cough, wheeze, stridor, painful breathing, ineffective breathing, nothing but dyspnea, and cyanosis. So if these 6 things are there, then these points toward respiratory disorder. Now we will divide this as we have learned in our MBBS internship period, that or during the time of learning, that any system what we do is we examine by inspection, palpation, percussion, auscultation. So we will move in that manner only. So number one is inspection. So come from upside down. In eyes, what can you see? You can see Horner syndrome. What is Horner syndrome? It is a triad of ptosis, meiosis. Meiosis nothing but the pupil size is reduced, and hydrosis, sweating is lost. Okay, so ptosis, falling down of eyelid, upper eyelid. Meiosis, pupil size is reduced, and hydrosis, loss of sweating. Remember this as PMA, mnemonic. PMA also says pulmonary. MA means malignancy. So pulmonary malignancy is the most common cause of this Horner syndrome, and this is a rare complication of ICD insertion also. Okay, so some apical tumor which is compressing the superior stellate ganglion, something like that. So that causes this Horner syndrome. So when there is Horner syndrome, suspect pulmonary malignancy, PMA. Okay. So pallor you can see in patients with respiratory disease if they have malignancy, or if they have chronic some chronic disorder. Okay, anemia of chronic disease you can see in these patients. So Horner syndrome and pallor you can see in eyes. In mouth, poor dentition and bad oral hygiene you can see in these patients. So this is relevant especially in pleural effusion. Okay, smokers and all those patients and tobacco chewers, smokers, all those patients will not have a good dentition and they will have a bad oral hygiene. That is also important in suspecting pulmonary abscess or aspiration, all those things. Okay, so eyes, mouth. Then come to neck. So in neck you can see engorgement of the neck and upper chest veins. Engorgement of the neck and upper chest veins. So that indicates superior vena cava obstruction. If there is engorgement and of neck and upper chest veins, if they are dilated, then it is SVC obstruction. There is trachea. See the trachea. There are lymph nodes in the cervical region. See those lymph nodes. So they can be a tracheostomy opening. They can be tracheal tuck. What is tracheal tuck? Tracheal tuck is movement of trachea downside during inspiration. Movement of trachea downside during inspiration. So this is seen due to excessive negative intrathoracic pressure. Okay, which can be seen in increased dyspnea, increased work of breathing. When there is severe breathlessness, you can see tracheal tuck. Or when there is airway obstruction, large airway obstruction, so there is negative intrathoracic pressure, so that will pull the trachea down. So these are the two things. And aortic causes can also cause tracheal tuck. So enlarged aortic arch or abnormal positioning of the aortic arch, what they will do, they will pull the trachea down. So these are the 4 causes of tracheal tuck. So you should go and watch the videos of these things. Unless you don't watch, you will not understand these things. Tracheal tuck, you go and just put the tracheal tuck. You can have videos, you just see the videos, the trachea gets pulled inside when the patient is breathing in. So, okay, so that will point towards severe dyspnea, and if there is no severe dyspnea, that can point towards some severe dyspnea due to upper airway obstruction, okay, and some aortic arch disorders. And lymph nodes, if you examine, you can have massive lymphadenopathy. That is also important. That can be due to infection, inflammation, and malignancy. 3 I's: infection, inflammation, and malignancy. So trachea, lymph nodes, okay, mouth, eyes, what you will see. Okay, now coming to the chest. Chest, what you will see. Inspection is when you are not touching the patient, you're just seeing the patient. What is the breathing pattern? So normally we will move like this. Rate of the, just remember, rate of respiration, depth of respiration, rhythm of respiration. Remember like this. So while examining breathing pattern in a respiratory patient, you examine the breathing pattern as rate of respiration, depth of respiration, rhythm of respiration. We will discuss. Okay. So normal respiratory rate is 12 to 20 per minute. If it is less, okay, that just you remember. You can see use of accessory muscles in case of severe breathlessness. What are the accessory muscles? The sternocleidomastoid, scalene muscles, and trapezius. These are the accessory muscles of respiration. They will stand out. They will stand out when there is severe breathlessness. Okay. So when there is severe airflow obstruction, so in COPD patient and in asthma patient, you can see these accessory muscles will stand out. This is found in patients in whom the external intercostal muscles and diaphragm are not sufficient to maintain normal gas exchange. On physical examination, intercostal retractions are visible. So that is also a pointer towards severe dyspnea. Patient may assume a tripod position. What is tripod position? Which involves stabilizing the shoulder girdle by resting the upper limbs against a hard surface. Patient sit like this on the bed, and he will just do in this manner. He will sit. This is tripod position. So by this, he will get some mechanical support to the respiratory system, and he will feel somewhat relief in the respiration. Okay, that is tripod. Example, most common is COPD patients. In chronic COPD patients, you can see they will sit like this. Now, accessory muscles of respirations, they will stand out in chronic respiratory failure patients and in patients with acute respiratory failure. In patients with chronic respiratory failure, there will be hypertrophy of the accessory muscles of respiration, as can be seen in patients with COPD or in patients with neuromuscular weakness. So accessory muscles will take on the task and they will get hypertrophy. So there will be hypertrophy of, so use of accessory muscles and hypertrophy of accessory muscles. Remember this point in chest. Okay, now inspiratory stridor and supraclavicular recession. Inspiratory stridor. Stridor is an inspiratory sound, and it is a musical type of sound which is heard during inspiration. Now again, you should go and watch this sound. I can't play this sound here because copyright issues will come. So go and just put stridor and hear that sound. Unless and until you hear, you can't examine. You can't detect that sound in your patients. You can't. That will be present, but you will not recognize that as stridor. So that is inspiratory stridor. So it is a very bad sign in patients, which will be if it is present. It indicates significant obstruction of the larger airways or larynx. Larger airways or larynx. Obstruction of larger airways or larynx. Either it can be acute, like in epiglottitis. This is common in children's. Epiglottitis is common in children's. Inflammation of epiglottis. Okay. Or in inhaled foreign body or laryngeal edema, for example, in anaphylaxis. Okay. It can be acute or it can be chronic also. Intra or extra luminal growths. Luminal means the large airways openings. Either there will be compression from the external side, or they can be obstruction from the internal side. So if there are growths like this, so they can be stridor, chronic, and it can be acute in case of epiglottitis or a laryngeal edema or croup, laryngotracheobronchitis. You will have stridor. Okay, inhaled foreign body, acute obstruction. So inspiratory, it is inspiratory sound. So if you auscultate, the patient may not have respiratory bees, bronchi, nothing will be there, clefts will not be there. You will hear normal breath sounds or reduced breath sounds, and you will hear there will be no sounds in the chest, but the sound is still coming. Okay, that is stridor. That is one point. Okay, that is one point. It means these are immediate points which are pointing towards the disease. Now, patient is insisting on sitting upright. Patient is not he is not agreeing to lie down. He is insisting on he is preferring to sit upright. So what that indicates? That indicates either cardiac disease or severe pulmonary disease. So that is orthopnea. Nothing but that is orthopnea. Orthopnea. Okay. This is seen in heart failure with pulmonary edema, limiting dependent alveolar edema to the lower zones of the lung. So mechanism is different in both cardiac patients, orthopnea of cardiac patients, and orthopnea due to respiratory patients. In cardiac patients, because when they lie down, there will be increased venous return, increased pulmonary edema, increased breathlessness. That's why they prefer don't lie. They prefer not to lie. In asthma and COPD, severe asthma COPD patients, they get some mechanical support when they sit in a tripod position. Okay, and they lie down, they will not have that mechanical support. That's why they prefer to sit. That is the difference in mechanism. Severe asthma and COPD gaining a mechanical advantage by fixing the upper thorax with rigid arms clutching the bedside tripod position. Okay, by contrast, many patients with pulmonary embolism and inflammatory lung disease like pneumonia or interstitial disease seem ready to lie fairly flat on their backs. There will be breathlessness, but they will not be they will not have difficulty in lying flat on the bed. See, not only in these diseases but also in COPD and asthma patients. They will also prefer, they can also lie down in the bed if they are not severe. If the COPD and asthma is not severe, they are also. So remember this point. Orthopnea is a classical symptom of pulmonary edema due to cardiac left ventricular dysfunction, acute left ventricular failure. It is a very important sign of. So first of all, you should think of cardiac disease when you're seeing a patient with dyspnea, orthopnea, and in some cases of severe COPD and severe asthma. Next, you should think like that. Okay. Otherwise, pulmonary patients usually they can lie down, okay, without any difficulty. So orthopnea is very important signs of cardiac disease. Okay. These are very important points. Okay, clinically you will see these things. So normal respiratory rate was 12 to 20. Now if the respiratory rate is more than 20, then you will say it as tachypnea. So tachypnea, when you will have tachypnea, okay, breathlessness. So cardiovascular disease you can have, pulmonary disease you can have, metabolic acidosis, metabolic causes like metabolic acidosis, anemia patients, severe anemia patients, hypocalcemic patients, endocrinopathies like hyperthyroidism or pheochromocytoma. Okay, psychiatric patients like anxiety or panic disorder, neuromuscular disorders. So these are all causes. So one is cardiac, second is pulmonary, third is metabolic, and fourth is psychiatric. Fifth, you should have neuromuscular. So you should evaluate in this manner only when there is a patient with the increased respiratory rate. Okay. So in metabolic causes, metabolic acidosis, you remember, and anemia severe, endocrinopathies like hypothyroidism important. Okay, you should remember these things. Now, one point here you should remember is this one. What is that point? This point. Note rates more than 30 beats per minute are often associated with onset of respiratory failure in patients with pulmonary or cardiovascular disorders. Patient with comorbid respiratory or cardiovascular disorder will go into respiratory failure when the respiratory rate is more than 30 breaths per minute. Okay, if they have comorbid respiratory or cardiac disorder, they will go into respiratory failure if the respiratory rate goes more than 30. Okay, that is tachypnea. Now coming to bradypnea. So this is rate of rate, depth, and rhythm. Bradypnea, nothing but less than 12. So respiratory centers are depressed. No, that's why because of depression of the respiratory center, respiratory rate should be reduced. So CNS disorders like elevated intracranial pressure, like due to hemorrhage, intracranial hemorrhage, or some mass in the what do you call intracranial space occupying lesion in the cranium. Okay, disorders of the brainstem. So these will cause decreased respiratory drive. Okay, and opioid or benzodiazepine overdose, hypothyroidism, metabolic alkalosis. Metabolic alkalosis itself cause decreased respiratory rate. How? So metabolic alkalosis, kidneys, what kidney is having? Kidney is storing bicarbonate. Okay, due to kidney there is alkalosis. Okay, so H plus will be less because of alkalosis. H plus will be less, and central chemoreceptors are susceptible to this, mainly H plus. Okay, so because there is decreased H plus, the central respiratory system will think that there is so much increased respiratory rate that so much excretion of carbon dioxide through lungs. That's why the H plus is decreased. The respiratory center will think like this, and respiratory center will reduce the rate of breathing. That will cause bradypnea. That's the mechanism in metabolic alkalosis. So remember these four important causes: CNS disorders or some poisoning with sedatives, hypothyroidism important, and metabolic alkalosis. CNS disorders, opioid and benzodiazepine poisoning, hypothyroidism, and metabolic alkalosis. Okay, these all cause bradypnea. Okay, bradypnea, these all will cause. That was about rate of respiration. Okay, you may or may not have a decreased saturation in this patient. Okay, decreased saturation. Depth of breathing. Depth of breathing is nothing but depth of inspiration. So I am not able to take a deep breath. Patient will say like this: I am not able to take a deep breath, or patient will take a very deep breath, very deep breath. Okay. So hyperpnea. Hyperpnea is like increased volume with or without an increased respiratory rate. So patient will take a deep inspiration, deep inspiration. Okay. So where you will see this in severe metabolic acidosis. That is called as Kussmaul breathing. Deep gasping respiration you will have. Deep gasping, labored respiratory pattern with increased frequency and tidal volume. So why this Kussmaul's breathing will happen in severe metabolic acidosis? Okay, Kussmaul breathing happens because there is a delay. No, because of increased pH of the blood. Okay, increased pH. So lungs will try to eliminate the carbon dioxide fast. So that's why there will be hyperpnea in these patients. Okay, pH is decreased, so to reduce the pH, lung will excrete more and more of carbon dioxide. So patient will have deep inspiration. Okay, hyperpnea, increased volume of respiration. Hyperpnea, increased volume of respiration. Diabetic ketoacidosis, again same, the pH is changed. Renal failure, again pH is changed. Toxic alcohol ingestion, so there will be acetaldehyde. Okay, ethanol will generate acetaldehyde, again pH will increase. Lactic acidosis, pH increases. Salicylate toxicity, pH increases. So wherever there is increased pH, there you will see increased volume of respiration with or without increased respiratory rate. Patient will have a deep inspiration, deep inspiration. Okay, deep breathing. So metabolic acidosis. Okay, diabetic, it can be diabetes, or due to renal, or due to poisoning. Okay, or due to salicylic acid toxicity. Remember these important points. So diabetes is the number one important, and then renal failure and poisoning. Poisoning can be due to some metformin induced poisoning, salicylate poisoning. Okay, any poisoning. So these three you can remember like this. Hypopnea is shallow breathing, meaning patient will say, I am not able to take a deep breath. This is the complaint from the patient, and they will say my breathing is superficial. I am taking a superficial breath. That will be the saying from the patient. So what will happen here? Here, hypopnea, shallow breathing, you can see in respiratory failure, particularly in the case of exhaustion of the respiratory muscles. This is followed by gasping. Gasping is single size, like this. These are gaspings. Okay, and followed by apnea, cessation of respiration. Okay, so hypopnea, shallow breathing, superficial breathing, not patient is not dipping breathly. That means patient is going into respiratory arrest. He can go into respiratory arrest. That is an impending sign of respiratory arrest, shallow breathing. So first number one thing you should think in hypopnea patient is respiratory failure. Either it can be due to exhaustion of the respiratory muscles. So there will be any respiratory patient which is exhausted. So first he will have increased breathing, then afterwards the breathing will become shallow, then patient will have gasping, then apnea, nothing but respiratory arrest. This will be the pattern of deterioration of the patient who is not treated. Okay, or if the treatment is not affecting the patient, so he will progress like this. Agonal breathing. What is agonal breathing? Breathe during dying. That is agonal breathing. Slow and very shallow breathing that may develop in patients with anoxic brain injury due to no blood supply to the brain. Due to any cause may lead to apneas. Apneas is nothing but respiratory cessation of respiration. Okay, so agonal breathing you can see in any patient which is going to die. Okay, that is agonal breathing. So patient will progress, deteriorate will like this. Fast breathing. Okay, then exhaustion we call hypopnea, and then size of breathing, and then apnea. So this, like this, patient will go into respiratory arrest. Now hyperventilation is a overventilation, increase in the rate and tidal volume, both rate and tidal volume, that is necessary for elimination of carbon dioxide. Hyperventilation will lead to hypocapnia. Hypoventilation is underventilation that is required for adequate gas exchange. It leads to hypercapnia. Okay, now this is important. Inspiration to expiration ratio. This is important. Under normal conditions, expiration is slightly longer than inspiration. It will be like this. So in hyperpnea, there is deep inspiration. So this in hyperpnea, this will be like this, deep inspiration. Okay, hypopnea, if it is this much, so this will become this much, shallow. Okay, and in normal breathing, this will be the pattern. This is normal. Okay, in hyperpnea, inspiration will become deep. Shallow breathing, patient will be breathing, have shallow breaths, okay. And in normal breathing, the expiration is slightly longer than inspiration. There'll be no gap, okay. There'll be no gap, okay, in between inspiration and expiration. This is the normal breathing, remember. So this is, if this is inspiration, this is expiration. So the inspiration will be short compared to the expiration, and there'll be no gap, okay. Remember this one. Now prolonged expiration is seen in patients with exacerbation of obstructive lung disease like asthma and COPD. So any obstructive lung disease will cause prolonged expiratory phase. Prolonged expiration you will see in obstructive lung disorder like asthma, COPD, also in acute bronchiolitis in children, acute bronchiolitis. So you will see a prolonged expiration. This is important, inspiration to expiration ratio. If inspiration is prolonged, that is deep breathing, hyperpnea, okay. If it is superficial, shallow breathing, hypopnea. Suggestion of this agonal breathing during dying, okay. Expiration is prolonged in obstructive disorders. Now, okay, now this was about depth of breathing, okay. Now coming to the type of breathing. So I said rate, depth and rhythm, no. This one more is type of breathing. So one is thoracic breathing and one is abdominal or diaphragmatic breathing. So in thoracic breathing, this is commonly physiological in women. They will just mainly breathe towards chest, okay. But other causes include severe ascites patient, large abdominal tumors, so any abdominal pathology, or some diaphragmatic paralysis, as well as in advanced pregnancy. So any abdominal disorder or anything which distends the abdomen will cause thoracic breathing, as well as it is physiological in women. And thoracic breathing you can see in diaphragmatic paralysis. Coming to abdominal or diaphragmatic breathing, more common in men than women. So men mainly breathe respiration through the chest. Contribution to respiration is less when compared to abdominal contribution. So mainly men will breathe with abdomen. So this is physiological in men. Other causes include ankylosing spondylitis. So this is a rheumatological disorder where the spine becomes stiff. So in those patients you can see abdominal breathing. Paralysis of intercostal muscles and severe pleuritic pain. If the patient has some chest pain, so he will not move the chest, so he will take breaths from abdomen. So any abnormality with chest will have abnormality with chest will have abdominal breathing, and any abnormality with abdomen or diaphragm will have chest thoracic breathing. Just remember. Now this is these things, okay. I will just scroll it up. This is nothing but rhythm of breathing, okay. This is rhythm of breathing. Rhythm of breathing, like you remember, for example, in ventricular, what do you call, pulse. In pulse you see rhythm, no. Regularly regular and irregularly irregular. So something like that. Here it is Cheyne-Stokes breathing, Biot's breathing interrupted by deep inspiration, sighing respirations, okay. So abdominal paradox and thoracic paradox. So Cheyne-Stokes breathing is something like regularly irregular breathing. Regularly irregular rhythm you see in atrial fibrillation, no. Regularly irregular rhythm. You will have this type of rhythm in Cheyne-Stokes breathing. In Biot's breathing, the rhythm is irregularly irregular. So this you see in some ventricular fibrillation or classical example in cardiac causes is this premature ventricular beats. There you will see irregularly irregular rhythm. So irregularly irregular rhythm you will see in Biot's breathing. Okay, how we will see Cheyne-Stokes breathing is waxing and waning of respiratory rate and volume, and includes spells of apnea. So respiration will be increasing, and then it will fall, gradually fall, and then the patient will have a period of apnea. Again respiration will go on increasing, gradually increasing in rate and volume. Again it will fall by decreasing rate and volume. Again the patient will have a period of apnea. So this type of breathing is known as Cheyne-Stokes breathing. Why this happens? Due to delayed or impaired signaling from respiratory centers. This is seen in heart failure, in neurological disease, or at high altitude. So Cheyne-Stokes breathing, again you should go and watch the video of this Cheyne-Stokes breathing, which is available in the internet, okay. What happens is, so when the patient has apnea for some seconds, so the respiratory centers will not respiratory center will not receive the response. There will be lag in receiving the response because of cardiac pump failure. Blood is pumping slowly. That's why that high carbon dioxide blood is taking time to reach the centers of the brain. So due to that lag in pumping of the blood, patient will have this apneic period. Again, when the patient have this apneic period, so when the blood reaches the respiratory center will receive a very high carbon dioxide PCO2 in the blood. It will detect. So because of very high carbon dioxide, he will detect. So respiration will increase very fast, and it will reach to peak. Okay, why it will happen like this? Gradually it will increase because again there is delay, because the respiratory centers will flush out the carbon dioxide, but still that normal or decreased PCO2 containing blood is not it has not reached the brain, the respiratory center. So when that reaches the respiratory center will think, oh, so much of carbon dioxide is lost because of respiration. So gradually again that will gradually the respiratory center will decrease the rate and volume of respiration. Again, because now again the carbon dioxide will increase at these points only, but because of delay in or lag of flow of blood, that detection is again late. That will cause apnea, and when till the point that blood reaches, the carbon dioxide will be very high. So this is the mechanism of Cheyne-Stokes breathing, which you will classically you will see in heart failure patients, severe heart failure patients, or when there is impaired neurological abnormalities, like in stroke patients. Okay, stroke patients or some neurological disorder. So in those patients you can see Cheyne-Stokes breathing. Okay, go and watch this. So Biot's breathing, so Biot's breathing is you will not have that regular. So that was regular. That is a rhythm which is regularly irregular. Okay, but this is irregular. You will have apnea anytime. You will have anytime increase in the respiratory rate, anytime decrease in the respiratory rate. That is not regular. Okay, that is irregular type Biot's breathing. It is a rapid, shallow. It is not deep. It is shallow, irregular breathing pattern with increasing episodes of apnea. Apnea episodes will be 10 to 30 seconds per minute. Biot's breathing. Okay, so irregular rhythm of respiration will be there in Biot's breathing. You will see an elevated intracranial pressure, CNS lesion at medulla oblongata, or drug-induced coma like opioid poisoning. So anything which affects the respiratory center you can have. So remember, just this is important here. Severe heart failure you can have Cheyne breathing. Next, anything which affects the brain can have Cheyne-Stokes breathing or Biot's breathing. Okay. Now this is important because this is very common in OPDs. So breathing is interrupted by deep inspiration. So patient will have normal breathing like this, normal breathing cycle. Okay, normal breathing cycle like this, but he will have some deep inspiration in between like this, and again he will have like this. Patient will be taking and he will take a deep sigh like this, and patient will say to the doctor that doctor, I'm not able to take a deep breath. And if you check the saturation will be normal. Patient will be a young female lady. So that type of respiration you will see in anxiety and psychoorganic disorders. Anxiety patients you can see, or you can see in psychoorganic disorders. Okay, so isolated deep inspiration, isolated deep inspirations or isolated deep expiration occur between normal breathing cycles, often with audible sighing. So that is nothing but anxiety, some stress. So this type of respiration you will see commonly in OPDs. Okay, and patient will think he will have some big disorder, like patient will be young, no, nothing will be there. Okay, so deep single sighing respirations you will see in stress or psychiatric patients, you can see. Okay, so that's about sighing respirations. Then abdominal paradox, we have discussed this in previous videos also. Abdominal paradox is also known as diaphragmatic paradox or paradoxical breathing. So this indicate diaphragmatic weakness. Abdominal paradox, what happens? So when there is inspiration, actually the abdomen should come outside, but during inspiration the abdomen will move inwards. So that is abdominal paradox. Thorax will be normal, but diaphragm will move inwards. So this you can see in neuromuscular disease, neuropathy, inherited myopathy of Pompei's disease, and usually requires both hemidiaphragms to be affected. And remember this very important point. This is a important point which shows that the patient may be in impending respiratory arrest. Abdominal paradox can indicate impending respiratory arrest. This can be associated with hypopnea with abdominal or paradoxical breathing. Okay, impending respiratory arrest. Thoracic paradox, I said no, 3 to 4 ribs injured, fractured on both sides. So that portion of the chest will move opposite to the other chest. So that is thoracic paradox, which you can see usually in flail chest injury patients. So that's about abdominal paradox, also known as diaphragm paradox, paradoxical breathing. You can see in impending respiratory arrest. So these are the we have learned about rate of respiration, okay, depth of respiration, type of respiration, rhythm of respiration. So you can take this paradoxes in type only. So thoracic breathing, abdominal breathing, and paradoxical breathing. Paradoxical breathing. So you can remember like rate, depth, type, and rhythm. Other signs which you can see, cyanosis, you can see in these patients, barrel-shaped chest in chronic obstructive lung disease patients, like in COPD. Reduced cricosternal distance, you can see. Tracheal tug, as we have discussed. Pursed lip breathing. What is pursed lip breathing? During expiration, this classical example is COPD. They will close during the sleep. You can observe they will like this. They will do. So why? During expiration, by closing the mouth, they are generating some kind of positive end expiratory pressure, because the airways usually close during the expiration time. So during expiration time, they will close their mouth, both the lips, and that expiration is against closed lips. So that will generate some positive pressure, and that will open the closed airways in these patients. That's why they will have pursed lip breathing. Prolonged expiration you will see in obstructive lung disorder. Hoover sign is a sign in inspiratory retraction of the lower ribs. The diaphragm, which is already flattened by hyperinflated lungs, may even reduce the intrathoracic volume by pulling in the lower ribs to which it attaches. So diaphragm, hyperinflated lungs, you will see these Hoover signs. Okay, so diaphragm is hyperinflated, it is flattened down. That diaphragm will pull the lower ribs. That is Hoover sign. Okay, that's about the thoracic examination which we have done. That is only inspection. Okay, that is only inspection. So other signs we'll talk in next class. For this time, this is enough. Thank you for your listening.